Hello, my name is Kunal Chandra, and today we'll discuss the Colles fracture and its closed reduction technique. So, what is Colles fracture? It is actually the fracture of the distal end of the radius, and it is named after the Abraham Colles, an Irish surgeon who first described it in 1814 just by looking at the classical deformity before the advent of X-rays. Colles fracture is a fracture of the distal radius, that is distal end radius, in the forearm with dorsal or posterior displacement of the wrist and hand, or distal fragment, you can say. The fracture is sometimes referred to as dinner fork deformity, dinner fork or bayonet deformity due to the shape of the resultant forearm. This is the X-ray of the Colles fracture. This is at the distal end of the radius. There is fracture, and the displacement of the dorsal displacement and the radial displacements. So this X-ray, this is the AP view, and this is the lateral view of the forearm and wrist. Next, please. So types of fracture at the distal end of radius. There are two types mainly. That is extra-articular fracture and the intra-articular fracture. Extra-articular fracture, it does not involve the radiocarpal joint, and intra-articular involves the radiocarpal joints. Extra-articular fracture may be two types: Colles fracture and a Smith fracture. And intra-articular fracture may be Barton fracture and Schoeffer fracture. Now we'll discuss the types of fracture at the distal end of the radius. These are the different fractures. Next, please. So this is the mechanism of Colles fracture when wrist is extension, open hand at rest, and if the wrist is in flexion, then leads to the Smith fracture. Colles fracture outward, you can say, hand in the outer stretched position, or wrist in extension, and here in flexion of the wrist or inward. Next, please. So a Smith fracture is just opposite to the Colles fracture. It is also called a reverse Colles fracture. It is a fracture of the distal radius, but less common than the Colles fracture. A Smith fracture is caused by the direct blow to the dorsal forearm or falling on the flexed wrist, as opposed to the Colles fracture, which occurs as a result of falling on the wrist in extension. But in Colles fracture, the fracture occurs when the wrist is in flexion. The distal fracture fragment is displaced ventrally or volarly, but as opposed to the Colles fracture, which is fragment is displaced dorsally. In Colles fracture, the distal fragments go in posteriorly or dorsally, but in this Smith fracture, the distal fragment goes or displaced ventrally or volarly. Depending on the severity of the impact, there may be one or many fragments, and it may or may not involve the articular surface of the wrist joints. Next, please. And two other fractures. First is Barton fracture. This is the intra-articular fracture. Is a fracture dislocation of the distal radius in which either the volar or dorsal aspect of the distal radial articular surface is sheared off with disruption of the radiocarpal joint. Next. And this Schoeffer fracture is also known as the Hutchinson fracture. It is a type of intra-articular oblique fracture of the radial asteroid process in the forearm. So now we'll discuss more detail about the Colles fracture. This is in X-ray. We can see the Colles fracture. There is the dorsal displacement and the radial tilt also displacements, and this AP view and lateral view you can see. Next, please. So these are the different displacements in Colles fracture. Colles fracture has 6 typical displacements: lateral displacement or lateral tilt, impaction, where 2 or more fragments are merged to each other, like fingers, you can say, cross fingers. This is called the impaction. Here two or more fragments are merged to each other. So during the reduction of the Colles fracture, we have to disimpact or disimpaction is necessary before the reduction of the Colles fracture. And other displacements is dorsal displacement or dorsal tilt and supination, where the distal fragments goes in supination, and dorsal displacements or tilt, in which the distal fragments displaced dorsally or posteriorly or extensor side. So these are the different displacements of the Colles fracture. You can remember by leads, LIDS, L for lateral displacement and tilts, I impaction, and next is dorsal displacements and the supination or distal fragments. So in this diagram you can see the dorsal displacement of the distal fragments. Always remember the term dorsal displacements means the dorsal displacement of the distal fragments. This is the radius and this is the distal fragments. This goes in displaced dorsally. So it is the dorsal displacements. But in case of a Smith fracture, reverse of this, there will be volar displacements, or in the opposite side of the Colles fracture. So this diagram showing the dorsal displacements of the distal fragments. And you can see here in a Smith and in the Colles fracture. Extension fracture of the radius is called Colles fracture, and the flexion fracture of the radius is called the Smith fractures. Next, please. So in case of Colles, there is a Dinner fork deformity. The triple displacements of the Colles fracture, that is dorsal shift, dorsal tilt, and radial shift of the distal fragments, constitute the classical Dinner deformity of the in case of this Colles fracture. After complication, also we can see this Dinner fork deformity due to the shape of the like the dinner fork. You can say in this next diagrams. This is the dinner fork, and this shape is coming in the forearm and wrist, and so it is called dinner fork deformity. The tissue which is ruptured on the volar aspect of the fracture is the periosteum, while the dorsal surface of the fracture, the periosteum and the fibrous part of the tendon sheath remain intact, and thus constitute the soft tissue hinge, which is the key to reduction of the displacement. So remember the volar surface of the tissue ruptured at the volar surface, but at the dorsal surface it is the periosteum is intact. Next please. In diagrams you can say this is the volar surface. Here is the disrupture of the volar surface or tissue, and there is the hinge at the dorsal side of the Colles fracture. Next please. In elderly patient, the Colles fracture is generally comminuted, and this is responsible for the slipping of the reduction, which is a rather common late fracture in this injury. Many stable fracture, that is non-communicated cases, can be reduced by the simple act of flexing the distal fragments and placing it in a volar direction into a line with the radius. Reduction in this case is demonstrated by convincing a snap, but this method will fail in an appropriate number of cases unless preceded by a well-executed movement designed to disimpact the fragments by increasing the dorsal angulation and applying the traction. So there is a technique to reduce the Colles fracture that should be biomechanically appropriate. Next please. This is the mechanical analogy introduced in the Colles fracture. Fracture in the displaced position, teeth incorrectly meshed here, you can say, like impact, and fracture distracted and backward angulation increased in the order to mesh the dorsal teeth correctly. And flexor will now bring the volar cortices correctly into the register. Next please. So now let's discuss the closed reduction technique. Sometimes it is important to have a muscular relaxation by local anesthesia. In the reduction of a left Colles fracture, the surgeon gripped the patient's forearm with his left hand and sighted on the volar aspect so that this thinner eminence is under the proximal fragments. The right hand of the surgeon is then applied to the distal fragments. The thinner eminence is being sighted on the dorsal surface. It is observed that the left hand of the surgeon remains stationary, acting as the passive hand or vice. Just we hold the by the this it is a left hand, and the right hand is used for actively to reduce the fracture, while the active part of the manipulation is executed by the right hand alone. So there are different steps for reduction of the Colles fracture. First is the disimpaction. And assistant takes hold of the elbow and offers counter traction. The surgeon or the chief who applied the plaster applies traction with the right hand, at the same time increasing the deformity by dorsiflexing the distal fragment, or re-engaging or disengaging the dorsal teeth. So initially we go for increase the deformity to disengage the fragment, proximal and distal fragments, and then we'll go for reduction and then locking of the reduction. So first step is the disimpaction, and next this is the technique of disimpaction, in which this is the assistant hand and there is the chief who is reduce the fracture. His left hand is holding the proximal fragments of the fracture, and here by the right hand he manipulate and reduce the fracture by first he go for increasing the deformity to disimpact the fragments, and then after disimpaction go for the reduction. So three process: disimpaction, reduction, and locking of the fracture by the pronation. So these three technical steps will follow. First disimpaction, then go for reduction, and then locking of the fracture by the pronation. Next please. So reduction with the traction is still maintained. By means of the right hand, the surgeon presses the distal fragment in a polar direction, and then follow this with the final flexion of the wrist. The thinner eminence of the left hand applies counter pressure against the proximal fragments during these movements. At the end of this movement, the fracture is fully reduced, but it would slip if the traction force were released, or if one of the two forces applying pressure and the counter pressure were removed. So importance of assistant is also important to maintain the traction and counter traction. Both should be maintained for reduction and after that locking of the reduction. Next please. So the fracture third step is the locking the fracture by pronation and applying the plaster in ulnar deviation and flexion of the wrist. So the fracture is now rendered stable by the surgeon pronating the right hand, thus carrying the distal fragment into the pronation, at the same time deviating the patient's wrist towards the ulna. If the pronation is maintained, the reduction will hold without the traction. This is explained by the fact that the proximal fragment in the Colles fracture can only slip out of alignment with the distal fragment by moving in the direction of pronation. But if the forearm is already in full pronation, it cannot be therefore move any further in order to lose alignment with the distal fragments. So after reduction, we go for pronation of the forearm and locking the fracture by pronation of the forearm and ulnar deviation and slight flexion of the wrist. Next please. This is the method of locking. Going forearm, locking of the reduction of by pronation. Here you can see the picture. This is the assistant hand. This is the chief of the person who applied the plaster and reduced the fracture. And this is the position when we apply the plaster in ulnar slight ulnar deviation and flexion of the wrist. Next please. This is the in which generally three fingers are used for traction, and left this little finger is not touched or not held by the surgeon or the chief, so that don't compromise the arch of the palmar arch of the hand. Next, please. So for mechanical reason, the ideal plaster aspirants for this fracture would be complete circular cast. But if there is swelling, then the fracture then go for slab. The ideal cast would be molded into a 3-point system against the polar aspect of the proximal fragment and the dorsal aspect of the distal fragment. Please. The plaster slabs should never be merely a dorsal slab, and it must always be a radial slab. A plaster slab is laid on the back of the forearm and bandaged into a position with a weight gauge bandage, and this position in radial deviation, this hand wrist will be in ulnar deviation and slight flexion. So this is the reduction technique in diagram. So there is the plaster of Paris cast, and fiberglass cast may also be used if there is swelling is reduced. Next, please. So after sometimes, if the deformity remains after removing the plaster, sometimes physiotherapy or rehabilitation is necessary. And their goal should be to control the pain, reduce contracture, reduce inflammation. This should be short-term goals. And long-term goals should be gain normal range of motion, gain normal strength, and gain normal function of the hand. So these are the different training for the hands movements by the physical therapist and the occupational therapist. Next, please. There may be complication if it is not applied or properly reduce the fracture. There may be carpal tunnel syndrome, compartment syndrome, reflex sympathetic dystrophy, stiffness of fingers and wrist joint, and osteoarthritis in late cases. Next, please. And this is the malunited Colles fractures. This is the deformity of Colles, that is Diener Folk deformity. If the reduction is not properly done by the surgeon or the chief who apply the plaster, there is chances of the malunited Colles fracture, and there will be many deformity. Thank you. Thank you very much. Have a good day.